Thank you. Thank you everyone for taking time out from your afternoon this weekend to come and attend our talks. So I'm here to talk about rotator cuff tears, which is a very common problem, especially from the middle age onwards. So what is the rotator cuff? Rotator cuff are muscles around the shoulder that help to move the shoulder in different directions. It's made up of 4 muscles, mainly the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. So among these 4 muscles, it's the supraspinatus that is usually affected in a rotator cuff, either tendinitis or tears. So most people tend to start getting shoulder pain from middle age onwards, which is about from 40 years old onwards to about 60, which is when it's most common. And the causes of rotator cuff tears can be divided into traumatic or atraumatic. Traumatic injuries can be something like a fall, which is very common, either with a direct impact onto the shoulder or fall onto an outstretched hand. Occasionally, it can be a result of more serious injuries such as shoulder dislocations as well. Of course, rotator cuff tears can happen without any injury as well due to degeneration or wear and tear. As we get older, the condition of the tendon degenerates, and it results, even without any injury, in slow chronic tears. So commonly, people do get pain, especially on moving the shoulder, typically this motion, lifting the arm, or they describe pain when they reach overhead for objects, and also reaching behind their back. Another common symptom is also at night during sleeping when they lie on the affected shoulder. So what are the different types of tears that we can see in rotator cuff? It can be a full thickness tear in which the entire tendon is torn completely from its insertion on the bone, or it can be a partial thickness tear in which only part of the thickness of the tendon is torn. It can also be a partial width or full width tear, meaning the length of the tendon can be torn, part of the tendon can be torn. So as I mentioned earlier, people usually have pain on active movement, which is when you ask them to move the shoulder themselves. If you help them to move the shoulder, usually there isn't much pain because they are not activating the muscle and therefore not using the tendon. They typically have a full range of motion. They can move their arm in all motions. However, it is quite painful, usually in 60 to 120 degrees, which is what is known as the classic painful arc of the shoulder. And when you test the affected tendon, which again commonly is the supraspinatus, they have pain when exerting strength on that tendon, and they may have weakness as a result of that pain. Pseudoparalysis is a commonly cited symptom, but often not often seen rather, because it usually involves a massive cuff tear in which 3 or more tendons are torn. So a lot of patients ask me, what happens now that I have a rotator cuff tear? Is it going to get better? Is it not going to get better? So generally, the prognosis is that 1/3 of them do improve, and the tendon does heal. 1/3 stays the same, and 1/3 gets worse. However, the issue is that we don't know who belongs in which third and what will happen. So usually, the treatment is non-surgical at the start. We do advise them to rest, avoid lifting heavy objects, or anything that may aggravate the pain. Pain relief is also another important mainstay of treatment. Usually we start with oral analgesia, such as anti-inflammatory. And if that doesn't work, we can offer steroid injections. Steroid, as you know, is a very strong anti-inflammatory medicine, so it can reduce the inflammation in the shoulder and therefore reduce the pain. Platelet-rich plasma is also another form of treatment that has been increasing in popularity over the past few years. However, the indications are not for all types of rotator cuff tears. It's usually indicated for partial thickness tears and on those that are on the articular side. Those have been shown to work very well. And of course, physiotherapy. So a lot of patients don't like to do physiotherapy. They would all like a quick cure, 1 tablet to solve their problems. But unfortunately, as with all musculoskeletal disorders, physiotherapy is one good way to slowly strengthen the joints and the muscles and to overcome the pain. So with rotator cuff tears, we can group them into 2 types of tears, either repairable or irreparable cuff tears. For repairable calf tears, of course, we will offer them arthroscopic rotator cuff repair. And for irreparable calf tears, there are a few modes of treatment now that for these patients. So we can, there are two modes, either insertion of a subacromial spacer, which is a smaller treatment, however, the effects are not so good, or the other option is a reverse shoulder replacement, which is a major surgery, but the outcomes are, functional outcomes are a lot better. So for arthroscopic rotator cuff tear, you can see from the photos, it's a keyhole surgery. So the incisions are very small. We use instruments to put it into the shoulder, and we try to repair the tendon back to the bone using suture anchors, which are just plastic screws with threads coming out of it. We use it to tie the tendon back to the bone so that it can heal. So it is it's not minor surgery. I would say it's moderate surgery. It can be done as a day surgery procedure. However, it has to be done under general anesthesia. And the recovery will usually take about 6 months up to 1 year, depending on the severity of the tear. After the surgery, patients will be usually required to wear an arm sling for about 6 weeks. This is to prevent excessive motion of the arm and to allow the repair to heal well in this 6 weeks. Subsequently, a lot of physiotherapy again is required to help the shoulder regain full range of motion and the eventual strength. So these are just some images showing how the surgery is done. We put instruments into the shoulder and try to pull the tendon back. So for irreparable calf tears, what are our options and why is it irreparable? So usually it's a result of the quality of the tendon. So in patients past 70 years of age, usually the quality of the tendon is so poor that even if we do repair it, the rates of healing and the outcomes are very poor. So, and also another factor could be due to the duration of the tear. In tears that are more than 3 months or 6 months old, it can be often quite hard to reduce the tendon back to the bone, to its insertion on the bone. So if we cannot pull it back to the bone, of course we cannot repair it. And again, the severity of the tear. If 3 or more tendons are torn, it can be quite difficult to reduce and repair all the tendons as well. So in these cases, the options can be, first of all, a subacromial spacer insertion, which you can see from the image, is a keyhole surgery in which we insert a small balloon to fill up the space between the acromion and the top of the humeral head, the bone. The other option is a reverse shoulder arthroplasty, which is a joint replacement surgery. So I'll touch on these two in a short while. The subacromial spacer insertion is a very minor procedure. It's a keyhole procedure, and its main indication is for pain relief. So what happens during a rotator cuff tear, or especially in massive rotator cuff tears, is that there's no tendon above the shoulder, and this leads to the bone rising up, and it can cause impingement against the acromion, the other bone on top. So by inserting a spacer inside, we can sort of reduce the shoulder, prevent it from riding up high. So this helps to relieve the pain caused from the impingement, and also helps to restore the shoulder biomechanics so that the shoulder can move well. As I mentioned, this is keyhole surgery. It can be done as a day procedure. It is very fast, can be done in 30 minutes. So these are suitable for patients who are unable to undergo a bigger procedure. So be it because they are not fit or, mainly because they are not fit for major surgery. So the benefit of this procedure is also that they can start moving the shoulder immediately after the surgery. There's usually no need for an arm sling or for any rest. They can start mobilizing as much as they can after that. And the next procedure, which is a reverse shoulder arthroplasty, is basically a joint replacement similar to what we have for the knee replacements, but it's in the shoulder. So the reverse shoulder is called because the configuration of the shoulder is now reversed. So instead of a ball and socket joint, we replacing the ball and socket joint with a ball and socket configuration, we replace the ball with a socket and the socket with a ball. The benefit of this configuration is that you do not need to rely on the tendon or muscles to move the shoulder, the rotator cuff tendons. We use the deltoid muscle, which is another muscle. So it's good in elderly patients because in which you don't want to rely on any poor healing of the tendon, which you may not realize whether it's healed or not until 3 or 6 months later, in which the patient has lost a lot of time. So it's indicated for patients who are generally between 60 to 65 years old with irreparable calf tears. However, the indications have slowly been expanding, and people have been using it for proximal humerus fractures as well, especially the more severe type of proximal humerus fractures, such as 3 or 4-part humerus fractures. It's considered fairly major surgery, and thus has to be done under general anesthesia. Usually, patient will stay about a day in hospital overnight, at least for some monitoring. After surgery, they may be required to wear an arm sling for a little bit of support for a few weeks duration. Subsequently, the arm sling can come off, and they will start physiotherapy again to help regain range of motion of the shoulder and to regain strength. Full recovery can be expected in 3 months. So the benefits of this versus repairing the rotator cuff is that the recovery is fast, the outcomes are fairly reliable. They can always achieve a good, a very constant range of motion of the shoulder. They can flex to about 120 degrees, which is about here, abduction of about 100 degrees. However, rotation externally and putting behind the back usually will be slightly limited. Okay, so that's it.